Hi, Lynn. Sorry I'm late. I'm going to start the webinar now. So you want, I could start it myself. I didn't see you there. I'm a little bit late. I'm very sorry. I'll start it right now.
The broadcast is now starting. All attendees are in listen-only mode.
We don't want to neglect country and western. Can you hear my voice? Thank you. I deeply apologize for being late. I guess I have a lame excuse. I guess I could say, the dog ate my homework or something, but the clock in my office is like like about a half hour off from real time. So I thought I had another 20 minutes to do some downloading, and somebody reminded me it was showtime, so I apologize. But this is not really going to be a class. This is going to be a lab. So labs are fun. Labs do not require a hell of a lot of work from me. It's like you're getting out of your chair and you're walking down the hall and you're going into the stinky laboratory and you're opening up the cabinet to get your microscope and you hope the bulb didn't burn out, and then you put it down and you take a half hour to try to make sure everything is working right, and then you make sure none of your slides are broken or stolen. Only now we get to do it all at once. So how this started out is that's exactly what happened at one of the medical schools I taught at. And then they switched over to digital microscopy, which made things quite better. But the students were then sitting in front of their microscopes, and it's nice to sort of be told what you're looking at, but they would like to see it. Somebody to show it to them. Yeah, this is a small thrombus. So that was my job. I walked around and I showed people what they were looking at. And I did that for a few years, and I thought, would it be better if I just sort of, like made movies and showed everybody so they're looking at the same thing together? Saves massive time. And it saved, even though the school had already spent $2 million for their big virtual microscopy lab, none of the students use it anymore. So I guess I cost somebody some money. For the people out there online, can you hear me all right? Yeah, looks like you can. Can you hear me just as good as Chicago? I think you can. So let's see if I can see more of your answers here. Okay, I get all positive responses. Couple of announcements for the real warm bodies, especially, based on a lot of the questions that were asked to me during breaks and between breaks and, in the cafeteria and stuff. I know there's a lot of exam anxiety. I have it too. It's something you never escape. You generally escape it when you're done with your boards, and then the state makes you, sit on a chair and prove that your butt was sitting in front of an auditorium for so many hours, and you give them the paper, then they give you your license and but the real anxiety really never goes away. And I know you're loaded with it, and I don't have that same kind of anxiety. My anxiety is that someday I'm going to stand up here and look like a stupid idiot because I don't know what I'm talking about. So let's say it again. Let's make this very clear. I have never flunked a student in my life. Even when the dean had a gun to my head, I told him to, well, I guess I can't say it without saying the bad words. I said no. That's not my job. The only exam that really matters is the USMLE. And that's what I base my course on. And another question that it's come up about, why don't you show stuff from Golion? Or why don't you, show something from board review books? Well, the course, how I originally designed and made all these PowerPoints, is that I read Robbins. And if you know, when you read it, there's something called a chapter, there's something called a division, there's something called a paragraph or a subdivision. It goes all the way down the tree, 5 or 6 levels. And I have a program that could extract those paragraphs and divisions and chapters, and I just filled in the blanks. So if there was something that was a page long on membranous glomerulonephritis, I finally got down to that level of the tree, and I said, well, this is what I really want to say to it in terms of what people want to know quick and what I think is important. And I did not put the whole page down there. I had a feeling that there may have been some students that thought that by downloading my PowerPoints and just reading them, that that's enough for the boards or USMLE. It's absolutely not. And it's not intended to be, and it never will be. So I want to tell you that when it comes now to the school exam, which is my exam, we're going to do exactly what I have always done for many years and what this school will allow me to do. We're going to review all the material before that exam. We're going to take an hour or two or a day or whatever it takes, maybe a whole session, and we're going to look at the yellow slides, and you're going to understand that what I think you should know, number one, to be good doctors, and number two, to have a solid outline when you have to use those so-called integrative approach when you sit before the step one, that this is what I, in my judgment, and that's what I get paid to do, make judgments, make opinions, that is what you need to do. So our exams are easy. If we've had, let's say, 5, 4, 3 chapters, if there's, 10, 15, 20 yellow slides per chapter, maybe we'll be looking at a total of 65 yellow slides. Guess what? I'm going to be making up 65 questions. So does that mean you don't have to go to class, you don't have to watch the movies, you just have to go home and memorize the yellow PowerPoints? Yeah, I guess so. But I'm not here to cause you any more anxiety, because we're all here for the only exam that matters. Now, I know schools, by law, due to licensing agencies, they have to give exams and they have to show grades. And, you know, I don't have to do it. The schools do. So is that okay with you? There's no reason for anxiety for tests. One of the girls came up to me and she goes, "Oh, you know the stuff that we're going to be seeing in lab, is that going to be on your test?" And I said, "No, you don't have to go there." But I think it's important for you to know that stuff, to reinforce with hopefully what you've already learned from the lectures, whether you saw them here or whether you saw them from your iPod on a webinar, or whether you saw them on your iPod, on your hard drive from downloading them. So that's the next point. All of the sessions that we have had so far, which has been 2, have been put on my M drive. And somebody taught me how to put an M drive with my name underneath it. So some of the stuff I think is under Jalan's, but there's a Dr. Minarsik there. And if you click it open, it'll say something like St. Kitts class videos or something. So everything that you see today, if you miss something or you're compulsive or you don't show up for class, which I see a lot of students haven't done, all they have to do is download it from the M drive, because at the end of this session, which is recording now in high resolution AVI format, is going to be put onto the M drive. And it'll be not low resolution compressed WMVs, it'll be high resolution AVI. You need that for pathology because of the intricacies of tissue resolution. If you're just showing, you know, PowerPoints with text on it, that's okay. But we have to have high resolution. So I have a separate third-party program recording that. I think I'm done with the announcements. Once again, if you have an iPad, if you have an iPod, if you have an iPhone, I don't think it's quite ready for the droids yet. But if you have an something, tablet or phone or iPod that you love to carry around, you could be attending class right now from it. So if you have one in your pocket, you could attend class both, you know, on your iPod as well as in this classroom here. I also want to extend to you the offer to share all of my slides. Now, when I was in medical school, we paid a lot of money just to rent slides, and then if we broke one, it was only about $10 or $15 fee. Probably now it'd be $100. But these 500 slides, about maybe 20 or 30 of which I'll be showing today, you can have free. And it's not like I've been pirating them or anything. These slides were made at the University of Iowa from NIH funding. So they're free to the public. And if you were to go to the University of Iowa and say, "I want those files," they couldn't charge you for them, because part of their deal is that they have to give them away free also. They may charge you a couple $100 for a handling fee to transfer those 60 gigs onto your hard drive, but it's free. Like, it's the wonderful thing about education is just like, it's too priceless to put a price tag on it. Okay, so if you want the FPXs, I got them on this hard drive. I got them on my mobile hard drive. I just put them on Dr. Nagy's hard drive. And if there's somebody here from class, you know, that's kind of like a computer geek that, you know, has access to unlimited speed and that, I would like for you to feel free to plug into this computer, get them on your hard drive, and start sharing them for the students that want them. The other thing, and the last thing that I wrote down, is something that is important also. This piece of paper has the word break on it. And I know that last time I asked the question, I generally like to take a break when I get tired. And sometimes I don't get tired for 2 hours. And sometimes I get tired after 20 minutes. So for those of you who have kind of built-in clocks and you get a little anxiety after 50 minutes, I want you to, and you know you'll probably be coming to most of the classes, I want you to hold this piece of paper in front of you, and when it comes time, we'll say 1 hour or whenever the rules are, I want you to go like that, okay? And it'll remind me that I better start thinking about slowing down a little bit, and we'll take a break at that time. So I'm probably going to give it to the wrong person, but I think the wrong person will know who the right person is. Can you hear me okay? The class can hear me okay? Can the online people hear me okay? Okay, so what we're going to do now is something that's going to be a little tricky, and I don't know if it's going to be easy to do or not. I don't know if we're going to be depriving the online people. I have to switch screens. Now, I was told that if I take this, all the IT people said, is that if you take this and you plug it into your laptop, which has the microscope, that everybody will be able to see then everything from the laptop. The reason why we have to do this from the laptop is because it was impossible. Everybody from here been down here for 3 days trying to install the microscope onto the desktop, and we installed it into the microscope into a few people's laptops. It works fine. But for some reason, it doesn't like this desktop over here. So what I'm going to do is hope that they were right. And I hope that it reaches. Because once we plug it in, we're going to be in lab. And even though you're sitting in something that looks like a lecture room or a classroom, you're actually going to be in a lab. And what I've done with the labs now for years is we just look at slides. And you know we're going to be looking at some normal kidneys first. And then we're going to have about, I don't know, I counted 15, 20 pathology slides, the stuff that you need to know. Now remember, when we were going through the lectures, we actually took still pictures and to show you things. But on the slides, it's going to be a glass slide. That came from a real patient, okay? This is what the medical students were using in still many of the medical schools in the United States. They get glass slides from patients. They look at them. They try to find things. These are exquisite, high resolution, extremely high memory digitizations of real patients' protoplasm. So if I cut off the online people, I really apologize, but I'm going to have to plug into the laptop now, and I hope after waiting late here, I don't disappoint you by cutting you off. But we got to go with the people that are giving me the money. Okay, I'm going to try it. Does anybody here know how to do this? Have you ever done it? Any computer geeks? I have not done it. Dr. Jalan did it yesterday, and it worked. So let's hope it works. Let's see. And we don't have any IT people here today. So I'm going to drop this down. Whoops, I don't think that was a good idea. And we're going to go into here. It works. And I don't know, in fact, I don't think the people online can see it. But I think the people online can hear me. The people online said it works. I'm really, really happy because now I won't be cheating anybody. One of my main goals in coming here was to try to unite online with offline, and it's been working very remarkably well so far. So what I'm going to do is just show you a bunch of cases, and some of them will be from histology. Now last year, did you all take histology? So has everybody here not taken histology? Human tissue, okay. When you took histology, did you look at slides, either virtual or glass? Did you use a real microscope? Did you use a virtual microscope? Or did you depend on just somebody to show you pictures? What's that? Okay, the Bacchus virtual program, that's good. So were you watching the slides, or were you controlling the slides? Watching. Were people telling you what was on there? So, in other words, you've never taken a glass slide or a virtual microscope and scanned around for things on histology, right? Okay, now, when you looked at all those slides, were they all normal histology? Or were some of them diseases? Normal, okay, good. Because we're going to start out by reviewing some of the normal diseases, some of the normal histology, before we go into the diseases. And I think a good place to do it is right here. Now, I took a couple hours, and I hope I got the mouse working here. I took a couple hours yesterday and today, and out of those 500 slides, which just have numbers on them, I actually correlated them with the list of cases from Rock Lab. If none of you have been to Rock Lab before, and you don't want to spend 500 hours answering all the slides like the online students will have to do, then you should at least know there's a place called Rock Lab, which is directly accessible from medicalschoolpathology.com. And when you go there, you see about 1,000 slides. And it looks pretty scary, but half of them are repeats. So there's really only about 500 slides in the slide box. And then what we do is if you click on the slide, you have yourself a virtual microscope, compliments of the University of Iowa. And they have enough bandwidth, so these slides have never, ever, ever slowed down because too many people are using them. And furthermore, if you click on the questions associated with the slide, which we will be discussing live now, there's another link. And if you have the patience and you'd want to download a larger file, like, you know, maybe 50 megabytes, for example, you'll be getting about a 5 or a 10-minute movie for each one. Now, I know nobody here is going to be doing all the slides, but during the course of this, I will take as many pertinent slides from Rock Lab as I can. Now, the very first slide is called KU kidney underscore 01 underscore 40XR. And they're arranged alphabetically, so I'm going to put this thing in front of me closer, and we're going to go to KU. Looks like the K's are coming up. And KU kidney looks like it's over here. So, in some of the computers I use, you can actually see thumbnails of the images. For some reason, in this one you don't, but that's no big problem. Because now, when we click on it, because we got the microscope to work in this one, we got the slide. And there might be a little annoying thing on the right side, which I really can't get rid of, but I don't care. I got a good mouse and I got good control of it. I always emphasize with the students in histology and histopathology that they should not freak out because they're looking at a million different things and they forgot the damn names of all the cells. What I tell the students is the most important is, even if you look at a few kidneys, even if you look at a few livers, even if you look at a few thyroids, comes a point very quickly when you just look at it and you know that's thyroid. And even if you forget the names of those little cells that secrete the calcitonin, they go by 3 different names, by the way. That's why I always forget them. I don't know, is this a C cell? Is this a light cell? Or is this a parafollicular cell? It's all the same thing. So here is what I'm going to ask you now. Can you all see the slide pretty well? I have found that the lower the light, the better you could see it. Now, the lights in front are as low as they could be. I don't know how to control the lights in back. Does anybody here know how to control the lights in back? If you do, why don't you try to dim them or turn them off even, and then ask for a poll to see if the other people in the lab can see their slides better. And of course, if you're looking at this from your computer because you're on the webinar, that's even better. That looks pretty good. Now here's the question, folks. I can see, at least I'm not going to trip over my feet. Can you all see the slides better now that the lights are out? Yes or no? Everybody's saying yes. Good. Then we'll keep them out or we'll keep them very dim. It doesn't matter with me. I could see here fine. So, you got to your lab. You put your glass slide on the stage of your microscope. You put your eyeball on the eyepieces. You adjust the distance. Then you focus for each one. And that's what you're looking at. And you could instantly see, you know, maybe I'll put the mouse over here. You could instantly see that this little button here, which you can, remember you could have all these slides, will enable us to blow up or blow down or even pan the slide back and forth, you know, just like you're doing on a regular microscope. I have found that panning is more of a bandwidth intensive problem, so I normally would rather just draw little rectangles and look at slides rather than pan the image around, because when I do it that way, everybody from all over the world can see it within 2 seconds. And the people that are out there, when I pan the image, sometimes it takes 4 or 5 seconds. So I might be talking about something that they haven't even seen yet, and that's not cool. So let's say that you're not sure what this piece of tissue is. Let's say that your eyeballs are about like mine. It just looks pink, like everything in histology looks pink. And then if you're really good, or you have really good resolution on your computer, you say, well, you know what? Maybe I'm starting to fantasize that there's some glomeruli there, but that's only because I already told you it's a kidney. So let's remove this guy. And can you all see the general rectangle that I've made? I need to hear from you loud whether you can see the rectangle or not. Okay, good. So now we just blew up that part of the slide. Now, even if you forgot all of the names of the cells, can you, and be honest, can you all recognize that as kidney? See, I ask these same questions to my online people, and there's like maybe, you know, I don't know, how many are there today? A bunch. There's always 4 or 5 that answer right away, and the others, you know, want to keep their mouth shut. So the same questions that I'm going to be asking them, and I'll see their responses here, but you can't. I'm going to be asking you. So online people, I have been reassured you could see the slides. So I'm going to ask you the question, can you see the glomeruli? Ooh, somebody said no visuals. Ooh, I'm very sorry about that. Can you hear me though? I don't know how I could fix that. Maybe I'll fix it for the next lab session, but I'm really, really sorry. So just like when we showed you the picture of the kidney several times during the lecture, we said you instantly recognize something called a glomerulus, even though maybe you can't identify, you know, the visceral epithelial cells called podocytes, the parietal epithelial cells, the urinary space between them versus the vascular space, the mesangial cells, the capillary cells, and maybe if you're really lucky and you look for a half hour, maybe you'll see a couple of cells from the juxtaglomerular apparatus. Does that name sound familiar? Because can I tell you something in all honesty? If somebody here doesn't know what a juxtaglomerular apparatus is, or they never heard the term, or they don't know that it's the cells basically that start the renin production from either histology or from physiology, you're going to have a really, really, really hard time with me. Okay. Now, the second thing that you know is when you just want to blow up the glomeruli a little bit more, is that this is a very good preparation. You can see nice loops of capillaries. I told you that almost 90% of the tubules that surround the glomeruli are probably proximal. And the reason I told you that is that because they are so loaded with microvilli on their apical aspect, is you can't see the lumen usually. On this one, you can see the lumen. On some preparations, the microvilli kind of wash out because they're so delicate. But we'll have to live with that because the histology here is exquisite. This is not a lousy slide. When the University of Iowa made their cases, they made sure that they had great slides. So basically, we're looking at tubules and we're looking at glomeruli. And the third thing that we talked about, whoops, maybe I'll have to pan it now. Take a look at the tubule here, just to the left of this glomerulus. Could you see how much thinner that is? And do you see how it seems to be coming in pretty close contact with the vascular pole of the glomerulus? That's definitely a distal convoluted tubule. Otherwise, all of these are proximal. And some of them look like they have some kind of fluid in them or slightly proteinaceous stuff. This is a normal kidney. Look, you can actually see the nuclei of the parietal epithelial cells forming the Bowman's capsule. The visceral epithelial cells here in the glomerulus itself are mixed in with mesangial cells and endothelial cells, because those are the only three kinds of cells you get in the glomerulus. Now, do you see all of these nice, beautiful little capillary loops? Well, if you look right here at the tip of this guy's finger, can you see that nucleus at the tip of the guy's finger? That's probably an endothelial cell, because it seems to be forming that little cytoplasmic thing, which is part of the capillary loop. The other two kinds of cells are a little bit more open, and to tell you the truth, no pathologist, in all honesty, no renal pathologist would try to venture to say what those other two cells are, whether they're mesangial cells or, you know, the podocytes, the cells that form the visceral epithelium. So you got a good feel for it. And I guess it wouldn't be fair if we didn't move around a little bit, zoom out a little bit, and try to find some nice blood vessels for you. And here, we'll look at this again. Here, check this out. We didn't see it good enough before, but we're going to see it good enough now. Whoops, that's not what we want. We could probably get rid of this whole picture, I bet. Whoops, I screwed up. Nice thing about it is that we could click on it again. Okay. Probably the tubules that you see under the guy's hand, because they seem to be quite flat, are the distal tubules, because there's not too many of them that look like that. In the cortex, most of them are the proximal tubules. Get a good general feel for the cellularity of a glomerulus, now that you know the three types of cells that are in there. Because let's say you think, well, you know, that's like about a normal number of cells in that glomerulus. But let's say the number of cells there was triple. You'd notice it right away. And you say, is there some kind of inflammatory process going on here? Could it be some type of glomerulonephritis? Even though you might not be able to see, you got to get a good feel for it. And also, we have been neglecting blood vessels, but I don't think it's going to be very long before we find some good blood vessels in here too. Even if we have to go down a bit and pan around a little bit. And here's my next question. Two questions. Is this cortex or is this medulla? Come on, you all know. Yeah, because you see glomeruli. Do you have glomeruli in medulla? Of course not. You got a lot of tubules and collecting tubes and stuff like that. What do you call the parts of the cortex that dips between the pyramids? Remember the renal columns? Does that kind of ring a bell too? So this is almost all cortical tissue, and I'm going to move it around a little bit. And maybe here, you're not seeing too many glomeruli. Could that be part of a medulla, perhaps? I don't know. Let's take it up. Let's blow up the southeast over here. Yeah, I don't see too many glomeruli here, so maybe that could be one. What do you see right here? what's that big white circle and that big white circle? It's a blood vessel, isn't it? It's an artery. It has a lot of layers of smooth muscle. So you know it's an artery. And if it's in the region of an area that is separating the cortex from the medulla, you know that the pretty good sized arteries that run in that general junction are the arcuate arteries, and the ones that are before them are the segmental, and the ones after them are the interlobular. So nobody can really tell what they are for sure, but they're pretty good sized arteries. They might be segmental, they might be arcuate. But when we look at some of these arteries now in the kidney, yeah, that's an artery. There's at least 5 or 6 layers of smooth muscle. Can you appreciate that? When you look at that, let's say that you saw, and we're going to see, an artery in the kidney that has a lot of inflammatory cells around it. It's not smooth and uniform like that. Might we say this was possibly a poly or a peri, or, for lack of a better word, an arteritis? Yes, we would. So, this is the world's most normal kidney. And I'm going to zoom back on it, and I'm going to ask you one last question. Do you see how nice and smooth that edge of the cortical surface is? What's the funny thing about that? Do you remember when you have the kidney in anatomy lab and there was a capsule, and maybe some of you actually stripped the capsule? Well, the capsule is fibrous tissue, isn't it? Like most capsules are. Has the capsule already been stripped from that cortex? Absolutely, because those tubules are running all the way to the surface. I don't see any single fibrous type material on that kidney. So when they did the slide, for one reason or another, might have been intentional, they decided to strip the capsule. You do not have to know the names of the cells, because the process of learning names and visual recognition are competitive with each other. But what I'm going to expect you to know soon, and certainly within the next few cases, that if you see something that's a kidney on low, medium, or high power, as long as you can see glomeruli scattered in with tubules, and they're all arranged kind of nicely, there's no infiltrates of inflammatory cells in the tubules, in the glomeruli, in the interstitium, the arteries look pretty good, that you're just going to have to recognize that as kidney. So let's move on to the next case. And once again, I apologize that the online people can't see this. Now, the next case is called P1 underscore 40XR. And of course, if I had thumbnails on here, I wouldn't even have to look for the numbers. So P1 underscore 40XR. Bingo. Whoops, did I press the wrong? Yeah, I pressed the keyboard on for the desktop rather than the laptop. And I'm not going to blow this up, but you have to recognize this instantly as kidney, instantly. So, rather than embarrass people, I want to ask you a question. Is there anybody here who didn't instantly recognize that as kidney? Please raise your hand. You know, I'm not going to hit you, but I will tell you, if there is somebody and they haven't raised their hand, I don't know how you made it through histology. That's a kidney. It's a little bit different case. Maybe it's a little bit different kind of a stain, but it's the same general pattern. It's cortex because you see a lot of mixture of glomeruli. You can see tubules in between. Oh, I don't know, let's blow up the thing a little bit. And this one, you could probably get a better feel for the blood vessels, because for some reason, they have a lot of nice red blood cells inside the blood vessels. And here's a blood vessel that has a pretty thick wall, so you know that's an artery. And, you know, maybe you can't see every little capillary in here, or maybe if you do, some may or may not have blood vessels. This is the same artery as this, probably. It's just turned a little bit when they cut the section. And once again, it's still a beautiful kidney. I bet you that nobody who looked at the kidney last year with Bacchus saw a better, more beautiful specimen. Also, another thing that you could appreciate better in this totally normal kidney is the fact that you have a lot of blood cells inside of those little nice capillary loops, so they don't look as quite open as they do. But once again, you can recognize there that absolutely is the nucleus of a visceral epithelial cell forming Bowman's capsule. And you can't really say on this glomerulus what is the vascular pole or what is the urinary pole because you don't see anything connecting it. But I bet you don't have to go very far before you see it. So let's just go down a little bit here on the microscope and maybe find another glomerulus somewhere and something that we can be sure about. So let's pan the image. Let's go to another beautiful glomerulus, like probably this one. And let's blow it up a little bit. Okay, now it looks like it's open. I don't think you could recognize a vascular. Maybe here, because the free edge, the tuft that doesn't touch the capsule is, of course, the urinary pole, and the part that looks like it's connected, maybe even connected if you're lucky and you spend a half hour looking for it, to some of the differentiated cells of the distal convoluted tubule. And if you're really, really lucky on a good day, and believe me, it would take me a half hour now, maybe you see some little granules inside of those cells. You know, that's renin, and that's the beginning of the renin-angiotensin-aldosterone axis. And those are the cells that are going to be pouring out those granules, degranulating them into the blood whenever there's a decreased blood flow to that kidney, all the way from the renal artery down to the afferent arterioles. Okay, do you have the feel yet? You want to see if there's any medulla on here? Yeah, there is. Look at this. Do you see here there's a lot of glomeruli, but here on the east coast, it doesn't look like there's many glomeruli at all. And let's prove that by doing what people do when they have microscopes, and that's go to a higher power. So yeah, so cortex on the left, medulla on the right, and you're both oriented the same as are. There's a lot of vessels now in the medulla, perhaps, you know, the various veins that are showing blood cells. If you see a pretty good size artery in the cortical medullary junction, good chance it's an arcuate artery. I like to use that example because the whole naming of the arteries of the kidney, you know, but you don't have to remember the names. Okay. At this point, I'm sorry the online people can't do it. We'll fix it next time. At this point, all I want you to do, remember, this is not a lecture. This is lab. All I want you to do now, take a deep breath, maybe close your eyes for a couple seconds and say, I can recognize a kidney backwards, forwards, upside down in my sleep because I have enough, I've learned the pattern recognition. Maybe you learned it before you even came here today. So now, when I show you this next slide, which is P1A40XR, which I think is going to be this one, you're going to say, well, I don't see glomeruli, because that's what you were using for your cue. But you do see a lot of medulla here, don't you? Just like we saw in the last case. And I don't think there's a single glomerulus here. Maybe there is, who knows? But those are all tubules now, aren't they? And there's a lot of blood vessels. So you get a good feel of how the interface between the tubules and the blood for, you know, reabsorption and stuff like that. But this is the most beautiful slide in my opinion, because if you remember yesterday, I asked you, were you ever lucky enough to cut through a kidney longitudinally and see a renal papilla? And a couple of you nodded your head. And you don't have to cut it a lot before you see it, maybe after 2 or 3 if you have a nice sharp knife. But what you saw grossly with your eyes as a nice little tip of a pyramid coming up, And what you saw yesterday as papillary necrosis, that nice little tip is no longer nice and pink anymore like the rest of the kidney. It's hemorrhagic, it's necrotic, it may get sloughed, it may be secondary to NSAIDs, it may be secondary to diabetes, it may be secondary to sickle cell, in which papillary necrosis is common. This papilla is very nice. Another reason why I really, really love this slide is that if you go in on it a little bit higher power now, we're going to take the tip of the papilla, and I told you as soon as you get to that papilla, you have now changed from tubular, which is basically a simple columnar or cuboidal epithelium, into transitional. And that's, here, I'm going to ask you a question you don't have to answer. Let's say that you had a cancer that started right there where the pointer is. What kind of cancer would that be? That would be a renal cell cancer, clear cell. It comes from the tubules. What if you had a cancer that came from a 0.5 millimeter over right there? What kind of cancer would it be? It'd be transitional cell, wouldn't it? Because that's where the transitional cells begin. And you know it's transitional, you recognize it's transitional, but it's not quite as many cells as what you see in the bladder. So as you go from where the transitional epithelium begins, at the papilla, all the way to the bladder and beyond, maybe even into the urethra, a little debatable whether we should really call that transitional or not. I called it transitional. One of my students, kicked my ass because he says technically it's sort of like squamous or something else, and I just told him he's wrong, but he was right. So that's the transitional. Tumors arising from that cell would be transitional, and those are the only two kinds of cancers. Okay, so we got the two pictures. We're looking at our microscope. Oh, I guess if you wanted to look a lot closer and see the beauty even more, we could do that. There you go. Beautiful transitional stuff. If you were to show just this part, to the pathologist that just won the Nobel Prize, whoever he is, and you said, is that from a calyx or a pelvis or a proximal ureter or a middle ureter or a bladder, he'd probably get the wrong answer. Or if he got the right answer, he'd be lucky because you just can't tell. All it is transitional. Okay. Another thing I want to point out is I think some of you might be saying to yourself right now, without wanting to bug me about it, is that chronic inflammatory cells sprinkled through the minor calyx there? And I say, well, yeah, it looks like there's more than just blood vessels or whatever it is. It looks like there's a few little scattering of lymphocytes, maybe some macrophages. Does that mean that you call that chronic inflammation of the kidney? Well, maybe you could, but remember, little lymphocytes are always spackled and sprinkled around everywhere, sometimes in great amounts, like mucosal lymphoid tissue, for example. So nobody would call that chronic inflammation in that part of the kidney. Maybe some real compulsive guy was. But remember, this is labeled as normal kidney, and it's really one of the most normal 3 kidneys I've ever seen in my life. So we're going to get dirty now. I picked out a few cases, and I think I did them in this order. Yeah, and I think it's a fair order. The cases that I picked these out with were from Rock Lab, and they happen to be alphabetically arranged. So when you go to Rock Lab, you have about like 29 groups of things for 29 chapters of Robin. There's one called kidney and urinary tract. And one of them, they then label them alphabetically, which is a fair way of doing it. It's not labeled according to the succession of topics that I talked about for the last couple of days. So let's go to 4303. And we're talking about kidney diseases now, aren't we? Looks like 4303 is going to be around here somewhere. 4303. And it doesn't give the name, it only gives the number. Whoops, I pressed the wrong button again. Okay. Folks, I don't know if your eyes are probably better than mine. So what I'm going to do is blow this up to the degree that you won't have any problems at all answering my next question. Is this slam dunk, instant pattern recognition kidney? Okay, thank you. Thanks. Thank you finally for somebody saying something loud enough where I could hear you. My ears aren't that great. And at least online, I don't have to worry about that because they type in their answers real quickly. Now, a lot of times, even if we're looking at things we haven't seen before, and now that you know this is all kidney, I know what you're instantly thinking. You're thinking there's something there in the southeast that's funny. Well, that's the recognition of all diseases. And it looks bluer, okay? And it looks sort of well-defined. And we all know that everything surrounding it is relatively normal kidney, right? So let's take that area and let's blow it up. Okay, well, once again, it looks the same. It just looks bigger, doesn't it? Do you see any glomeruli around it? Yeah, you do. Here's one, here's one, here's one. Tubules. What I do with my online people is that, some of them even get the diagnosis from the thumbnails before I even blow it up. And I call those people wise asses. But I really appreciate the fact that they pick it up quickly. At least when they yell out the answer, nobody hears them. I'm the only one that sees it. But let's not freak out thinking this is some weird, wild disease that you'll never see. This is absolutely one of the most common types of pathology that could happen to a kidney. And so let's blow it up even more. Okay? Want to blow it up more? Thank you. Let's say you go back to your basic histology, and I say, what are 99% of all those cells that are on the West Coast? What did you say? Lymphocytes, was that your answer? Okay, here, let me ask you this. That's a pretty good answer. But can you actually see dense chromatin, which is nucleus? Is the other stuff part of the nucleus, or does it look like cytoplasm? So you got what looks like a sprinkling of cells, and are the nuclei round, or are they a little bumpy in general? Okay, they look bumpy and they have cytoplasm, so that kind of rules out lymphocytes. So let's say that you really had a good microscope, and this is not good enough, but on some of the really good microscopes with oil immersion, I'm going to blow it up even more. And I'm going to tell you, this fuzzy stuff is cytoplasm, but look that has kind of a lobulated appearance, that has kind of a lobulated appearance, that does, that one looks a little round. But most of these cells, you'll agree, there's a classical Mickey Mouse lobulated cell. What are these cells? Absolutely neutrophils. So what do you call a localized collection of neutrophils? Perhaps very well defined, or perhaps even encapsulated. What is the pathologic definition for that? It's an abscess. Now let's say you cut this kidney open and pus came out of it. Well, you call that an abscess. Let's say that you cut open the kidney and you didn't really see pus, but maybe there was a funny discoloration. But now microscopically, you're seeing totally well-defined areas of cells that are neutrophils. And that's what an abscess is. It's just a walled-off bag of pus, maybe some fibrin, maybe some necrotic degree. And it's almost all neutrophils. So I think you already know the diagnosis for this case. Or if you don't know the diagnosis, let's diagnose it ourselves. Renal abscess. If you're honest enough and you don't think you could see it with your naked eye, then call it a microabscess. And so the kidney's infected. Okay? Well, what's the usual kind of bug that infects the kidney? Gram-negative, ascending Gut bugs? Yeah. What's always at the top of the list? E. coli. What usually is at the second one on the list? Pseudomonas is usually second on the list. This happens to be Pseudomonas. But is there anything on here that makes this Pseudomonas? Like if I told, my chairman at the University of Chicago that this was E. coli, would he believe me? Yeah, of course he would, because you can't tell. All you could say is that it's an abscess, and if you had a nice bacterial stain, you might be able to see it. But better yet, if you got the specimen, from surgery or autopsy, and it was big enough to see, you would rub a swab on it and just culture it. And then it would culture out and look exactly like Pseudomonas should. Okay, this was not too bad of a case, was it? So let's move on. We got a few more, and we'll be probably moving faster as time goes on. And as soon as somebody waves that little paper, I'll know we're going to take a break. But I know we're not anywhere near that. I just wanted to remind you, when you think it's time for a break, wave it around. Next case. And of course, if you're on your computer and you're at Rock Lab right now, you probably know what the next case is. You could cheat and you get all the right answers, and I'll really be impressed. It's going to be number 148. And these are all things that we saw, and they're all things that are logical as well. So here's 148. Okay. Question number 1. Is it pink? Sort of, yeah. Is there blue in there? Yeah. Can you see glomeruli? Well, I'm really good at this because that's what I've done for a living my whole life. I could tell you these are little glomeruli, but in all honesty, all you could say is that, there looks like there's some little balls there that, could be. And sure enough, as soon as I did that, you said, instant pattern recognition, this is kidney. And you can see glomeruli, you can see tubules, we could move around to some blood vessels. And this is a relatively sort of normal-looking kidney, so you're saying, well, why the hell is he showing us normal stuff? This is supposed to be pathology lab. Well, look at, what do you think this stuff is now? Do you think there's some peppering of cells in or around tubules there? And question number 2 is, I'm going to do the panning. Is it getting worse? It's not quite like a microabscess before, where it kind of was only inflammation, nothing else. It seems to be blending in with it between the tubules and maybe even involving glomeruli, but it looks like it's mostly in the tubules. Because look, the glomeruli here looks normal, that looks normal, that looks normal. But sort of like that's normal, but the stuff between them, where the tubes are, have some kind of peppering of cells. So, let me ask you this. What kind of cells are they that are in and around the tubules? Do you want to call them lymphs, or do you want to call them neutrophils, or do you want to call them... Here, the question is, are they polymorphic, or we call polys, which mean neutrophils, which means acute inflammation, or are they mononucleated? In other words, lymphocytes and macrophages, which are the hallmark cells of chronic inflammation. Does anybody want to give me an answer? Poly or mono? I don't know the answer. That's why I'm asking you. How many vote poly? I vote poly too. How many vote mono? At this point, everybody's afraid to say mono. I'll blow it up a little bit more. And for those of you who weren't really 100% sure that they were predominantly polys or neutrophils, are you 100% sure now? So, what do you call it when you have a bunch of acute inflammatory poly cells predominantly in and around tubules? You call it, could you want to call it pyelonephritis? You could. Would you want to call it a tubulo-interstitial nephritis, which is definitely a different disease category? You could. If you saw a lot of these within the tubes themselves, would you be more tempted to want to call this pyelonephritis? So at that point, I'm almost obliged to show you a bunch of these inflammatory cells in the tubes, ain't I? This is classical stuff. This is not exotic stuff. Here you have inflammatory cells around the tube and in the tube. So yeah, this could be a tubulointerstitial. The diagnosis for this case, if you're at Rock Lab right now, and you're looking at one of the things at the top of the list alphabetically, is kidney, parentheses, acute and chronic pyelonephritis. Now I know what you're thinking. You're thinking, well, you know, if he told us most of these are acute polys, how come they're calling it chronic too? That means that somewhere along the line, somebody says, well, you know, these are not really all neutrophils. Come on, there's some lymphocytes in there, there's macrophages, and that's why pathologists sometimes will say acute and chronic. Or maybe there'll be another area where there's a lot of lymphocytes. And you can recognize lymphocytic infiltrates instantly because they're extremely blue, because they have almost no cytoplasm and the nucleus is perfectly round. So they look infinitely bluer than the areas of acute inflammation. And, oh, let's find the area that's really, really blue. And I bet you we'll see more lymphocytes there. Oh, maybe not. No, those are mostly polys. Quite frankly, if you said, well, Dr. Minarsek, I want to take the guy that made that slide and, you know, and spank his hand with, you know, the ruler because it's predominantly acute, I wouldn't blame you because I think I would call it predominantly acute myself. But sometimes pathologists want to do the thing they call CYA, you know, cover your butt. And they want to make sure that if they call something acute, that somebody's not going to come around and find some lymphocytes and say, well, look, it's chronic too. So a lot of times they'll go both ways, only so nobody could accuse them of being wrong. And I know that you do that yourself as well. Like if you have a severe meningitis, we mentioned this the other day, and it goes a little bit into the brain. You say, well, I better not call this meningitis because somebody can see there's a little involvement to the brain, and they're going to call it a meningoencephalitis, and then somebody's going to say I'm wrong because I just said meningitis, you know. So that's the way it goes. Take a deep breath. Be proud of yourself. You got 2 diagnoses correct. And we're going to do another case now. And I'm hoping that you are with me on these cases because I'm trying to explain this in the very, very, very best way possible. And I know that a lot of these concepts you're more than abundantly familiar with from Path 1. Whether you actually got a chance to use them now in your regular daily life, I don't know. So let's go to 4699. And even though this is taking a little bit of time, I don't know if you remember when I was a kid, of course you don't, but you know, you'd have to get the slide out of the box, you'd have to dust it off, you have to make sure it's not cracked, you have to put it on the stage. You know, it was a real hassle of a thing. Now, all you gotta do is basically just kind of scroll down and click on it. 4699. Here we go. By the way, when I highlight the icon there, can everybody see the 4699? Yes, no? Yes, okay, everybody can see it. Question. Does everybody recognize this slam dunk as kidney? Thank you. I really appreciate it when I just hear somebody say yes or no, and I really don't care if it's wrong, because if it's wrong, I'm going to teach you something, and that feel good, and if you already know it all. Now, remember when we saw the last kidney, and I asked you, was the capsule stripped away or not? Well, let me ask you this. If this is the cortex, and this is a whole bunch of fibrous tissue here, do you think that that capsule was stripped away? No, it's still on there. Remember in the first one we saw, the tubules went all the way to the surface of the specimen? Okay, boy, this one certainly has a lot of glomeruli, doesn't it? It might, some of these slides are actually not from humans. They might be taken from pigs or rabbits, something that has better glomeruli or something. I'm assuming this is a human, but if it is, already you know this slide has more glomeruli than what we're used to seeing. And what I'm going to do now is just take this middle portion and put on my plus thing and blow it up again. And certainly the glomeruli are more towards the surface that has the capsule, which is where they should be, which is why it's called cortex. And, oh, you can see some nice big blood vessels here too, can't you? And what else? Well, it doesn't look like we could see like really good tubules between these glomeruli, doesn't it? Isn't that what instantly kind of comes to your mind? So, we're right. You can't really see good tubules. You can see some tubules. But it looks like there's a lot of inflammation going on, not where the glomerular are, but where the tubules are. So I wrote down a couple questions. Number one, capsule. Yeah, you can see the capsule. Here's the second question. Whatever this inflammatory process is, does it spare the glomeruli? It looks like it is. Looks like the glomeruli are pretty nice, doesn't it? Let's move down and look at glomeruli just to be sure. There you go. They look like they're pretty normal. See, on this one, you can actually see a vascular pole and a urinary pole here. On some of the other ones like this, you can't because there's no connection. But what can you say? Well, there's inflammatory cells here. I think most of them look chronic to me. I guess they could be acute, but most of the cells that are in and near and around the tubules, they look kind of round. This one, the diagnosis on this case was called also acute and chronic pyelonephritis. But you want to know something? We're missing the boat here. You want to know why? Because do you see all those tubules in that inflammatory region? Do you think that the stuff inside the tubules is a little pinker than what you normally see? Maybe it's inspissated. Could somebody mistake that for a thyroid on a bad day? That's thyroidization. When we talked about chronic pyelonephritis having some inspissation because of stagnation of fluid, getting denser, more filled with proteinaceous material, staining pinker, that's called thyroidization. Now, to me, it doesn't look like a classical thyroid, but I can understand where this is a good example of thyroidization. See that? Okay. Same diagnosis as before, only this one is now more chronic because you call that thyroidization is mostly with chronic. The next one is kind of a tough case. What time is it? Is it time for a break? Let's do it 10 minutes. How come you didn't show me the sign? Because you were having such a good time, right? Okay, well, let's take a 10-minute break. I'll do a couple songs. You know what? I have to run away, so could you do the next two after my first one? And then we'll start the rest of the lab. And I don't know if this is going to work. Would you do me a favor, just start the songs? I have to run to the next one.
of Chicago on you. Oh, what the hell's going on? What? This is like the... Ha! No, thank you. Yeah.
Thanks a lot.
Quick question. What are you going to teach tomorrow?
I'll probably start with CNS. Yeah.
How long will it take to finish? 2 days?
CNS, at least 2 days, maybe more. It's a big chapter.
Okay.
Yeah.
What
I
about-
thought if the lab would get done early today, which it's not going to, that would probably go into CNS today, but I don't think we're going to have time to do that.
Okay. Tomorrow you're going to start CNS.
Yeah.
Skin, how long does skin take?
Maybe not quite as long as CNS. And of course, that largely depends on lab too. Because if the lab, like this is a good sized lab, like there are some things like neoplasm where the lab takes just as long as the lecture, but in most cases, the labs take about half as long as the lecture.
Okay. So CNS, how many days of lecturing and how many days of lab?
For with the next 2 chapters,
For CNS.
CNS is not a big lab. It's probably 2 days lecture, half a day lab, let's say.
2 days lecture?
About.
Okay, then start CNS tomorrow.
Yeah.
And Dean asked me to tell you that we have a meeting with him tomorrow, 9 o'clock.
Okay.
Okay?
Okay, 9 o'clock.
In the morning.
Okay.
Okay?
you showed. I think it was like the first one that you said was,
You mean the slide here, the
Yes.
microscopic slide?
yeah, like one of the first one. It looked like it had a crescent shape.
Uh-huh.
Did you not see that near the glomerulus?
A crescent shape. You mean the glomerulus one's crescent shape?
Well, you had one of the diseases as crescent.
Yeah, the
shape.
crescents are in a rapidly progressive glomerulonephritis.
Okay, so.
But
is
that
it-
wasn't on any of the slides we saw today.
Oh, no, I
If
thought
it was something else. Some of the slides have little artifacts in them where it looks like the tissue is just kind of folded back or
Okay, so
jagged.
I just saw one. Would you see
Absolutely.
a lot
There-
for the crescent?
Yeah,
Okay.
sometimes. I'll be showing you a case in the lab later.
Okay, would you see neutrophils with that?
Sometimes, but remember the crescents are predominantly macrophages.
Macrophages.
Yeah.
Okay.
Okay.
Okay, thank you. Sorry, I have another question.
Sure.
Do you do EM pictures? Electron and microscopy?
Yeah, not here, not for lab.
Okay, because do they have them on the stuff for the shelf? 'Cause-
Well, they have them on the PowerPoints that I showed, when it comes to glomerulonephritis. But they don't have like a virtual EM viewer online or anything like
like,
that.
would we be able to see some diseases with EM pictures? That
Absolutely, like we did during class. Remember,
during
we
class?
looked at the
Okay.
basement membranes and saw lumps and bumps and that.
Yeah, I was
Yeah.
wondering if you don't
Did
be
you
able
go to the PowerPoint? You'll see a good number of EMs there. And all the EMs I have for kidney diseases are the ones that just show the diagnostic parts.
Okay, yeah, because I was noticing you have to look at like the podocytes and stuff. You
Yeah,
wouldn't be able
yeah.
to see them with this.
Yeah, no, you could never ever see them on here. They're just too
Okay.
small. You
Okay.
can't even see basement membranes.
Okay.
That's why most of the diagnostic renal pathology is EM. And I'm going to mention that again
Okay.
because it'll explain why we're not going to be showing glomerular diseases.
Yeah, that's right.
Can you hear me? You probably can. If there's anybody left online, I just want to tell you, you will not be able to see the micros. We had to use it on a different computer here. But I'm pretty sure you can hear what I'm talking about, if that matters. But if you can hear me but not see me, that's just too bad. But if you go to Rock Lab and I give a number for a case, like for example, the next case we'll be seeing is 4153. If you look at the images in Rock Lab, do a right mouse click on it, you'll see 4153. You'll at least know that's the case I'm talking about. But for some reason, due to my control, you won't be able to go to this lab, which means probably everybody went away. But I'll try to fix it for the next lab. Bye-bye. For those of you that are still there, I appreciate it. Okay, well, we cut off the music near the end because we had to switch back to the other computer again. The online students couldn't see the slides, but I told them if they go to Rock Lab and they go to the numbers on the slides that I'm talking about, they'll at least be able to see the slide. Of course, you have the benefit of seeing everything. Like, for example, the next slide we discuss will be 4153. So if the online people go to 4153, and at least they could hear me by doing a right mouse click over the slide, they'll be able to tell what number it is. And it's alphabetically arranged, so it'll be there near the top of the list. In fact, I could even give them the title of the slide, but then it'll spoil all of our fun. And another thing, I'm glad somebody came by during the break and asked the questions about the glomeruli. We mentioned this before, and I'll say it again. Most of the glomerulonephropathies, of the glomerulonephritis, you cannot diagnose on routine H&E microscopy. That's why most pathologists lose their ability to diagnose glomerulonephropathy, because they're all sent out to the renal lab. You know, they never get a chance to see them like the routine stuff. So if you're wondering why I'm not going to show you in a membranous glomerulonephritis or an acute post-streptococcal glomerulonephritis, it's because you just can't see anything. The changes are too small. They involve very, very tiny changes on the basement membrane, and those are not part of the H&E set here. If they were, you wouldn't be able to see anything anyway. So, I don't know. Another person asked that perhaps when we look at the slide, we could say a little bit more. I can't give the entire lecture over again if we see acute pyelonephritis, because we did that yesterday. But I can say if, for example, if we saw some thyroidization, we could say, what did it do to, and maybe go back into some of the clinical findings of what might be going on with the patient. I try to do that as much as possible as well. And if you actually do these slides in Rock Lab and you blow them up using the online viewer, there'll be a set of 3 or 4 questions about each case to relate them back to the diseases. And and if you don't know the answers, you can then just click on the movie that goes with them, the high quality movie, which is also on YouTube, by the way, under the name Histopathology something, and get the answers that way. But if you don't have to do the exercise, you probably won't wind up doing the whole thing except whatever you think you're curious about. So let's go to case number, slide number. Let's see. No, I don't want to go to that one yet. Let's go to slide number. This is going to be a tough one. I don't know if I should do that one. Yeah, I think we'll do it because it's going to show us some general principles involved. It'll be case number U753. And I'll get that mouse out of the way. We're down to the U's, U753. Well, do you recognize that as being anything? Maybe not. It looks kind of pink. I think you can see areas that look like they're really blue. So maybe you're thinking that might be some kind of inflammatory infiltrate. Let's see if, in all honesty, I want to ask a question. Can anybody recognize glomeruli in that slide yet? I have a hard time too. That's why I'm going to zip it up a little bit here and go to an area where maybe we'll see some glomeruli. Ah, there's one. There's one. There's one. There's one. Okay, so now are these all easily recognizable glomeruli too? You know it's kidney. You can see tubules around it. But in addition, I think you have to be honest, and you could say that once again, some of those tubules look like they might have a lot of mixture of inflammatory cells. Not so much the glomeruli, but let's say an area like this, okay? You know that that doesn't look like normal kidney. And you can see a bunch of lymphocytes, oh, I shouldn't have said it, cells infiltrating between the tubules. And you know if it's predominantly between the tubules, and you're tempted to call it an interstitial nephritis, and then run down the differential diagnosis of all the things that cause interstitial nephritis, you might remember, besides infections, certain toxins, we said chemotherapy, we said deposits of uric acid and calcium. The one thing that was at the bottom of the list was transplant rejection. Now, can you tell from looking at this that this is a rejected kidney? No, you can't. But what can you say in all honesty? Well, you could say in all honesty the glomeruli don't look too bad, and the tubules look like they have a lot of inflammatory cells between them. So if you wanted to say interstitial nephritis, that would be the correct diagnosis. But then you have to remember, I just rattled off the differential of that. And in this case, the interstitial nephritis was called chronic. And do you also happen to agree that almost all those cells are mononucleated, like lymphocytes? So that's another reason for calling it chronic, isn't it? Now, I'm sparing you the agony of showing you all the three different types of renal rejection. I mentioned it. And if I just went through it, it would be just as confusing to me as to you. But I want you to remember the principle is that when you do a renal transplant, of course, nowadays you go through all the right typing for donors. You make sure there's proper immunosuppression. And you know that your transplant has a very likely chance of working. Okay, you know that long term, most people that get renal transplants, especially younger people, they don't last forever, do they? That there's a very, very high failure rate with time. But a chronic rejection is not something that would happen, like in a day or a week, maybe months, or more likely even years. So let's just say for now, if I could find the slide, that we see cellular infiltrates in the interstitium, and it's a transplant rejection. Now, in acute rejection, the changes are more likely in the endothelium and causing blood vessel damage, because that's acute. In the late acute and chronic rejection, you see cellular infiltrates. And of course, in a long-term chronic rejection, remember this goes along with the phases of inflammation, you're more likely to see fibrosis, sclerosis everywhere. You don't see damaged vessels here. You don't see arterioles. You don't see a lot of fibrosis throughout the kidney. You see cellular infiltrates, mostly chronic. So this is in the middle range, isn't it? And the reason why I showed you the middle range is because I don't want to have to show you all three. And you should remember that interstitial nephritis, if you kind of remember from your PowerPoints, has several causes, that this is one of them. Okay, let's go to the next case. I told you it was going to be tough. Go, yes. No, I think the stuff in the tubes, I think some of it is inflammatory stuff, but it's granular, isn't it? It doesn't look like a colloid. It could be some degeneration of the tubes. It could be some inspissation, but it doesn't have that colloidal or gel look. Now, but your question is very good. You say, well, if we were told that thyroidization can occur with chronic pyelonephritis, what about if this inflammation in or around the tubes was long and chronic? Could you see thyroidization with that too? I would say good chance, but I wouldn't call that thyroidization. It doesn't have a fluid, colloid type of homogeneous appearance. It's granular. You could even see crud in there. Good question. Let's go to the next case. That's the one I thought was going to be hard. Let's go to the next case. Really easy case, K304. And I think you'll probably get the diagnosis even if it was on the thumbnail. So there's K's and there's 304. In all honesty, you don't know what that is, do you? Or I could say it's some kind of tissue that has a lot of big cysts. Now, can you see glomeruli on here? I don't know. Let's zoom up the northeast corner where there seems to be something besides cysts and see if we could recognize glomeruli. I could see somebody said, already. There's a couple of glomeruli, but there's not many of them, are there? This may be a kidney that just doesn't work anymore, or maybe a kidney that never really worked. And it's almost not right to show this as a microscopic slide because I think even if you didn't look at it under a microscope, before you took the slice in, you know that that kidney is all cysts, okay? So you go, oh, it's multiple cysts, polycysts. This is polycystic kidney disease. Okay, there's some remnant of glomeruli and tubules, and most of it is just cysts. And if you remember the pictures that I showed you from polycystic kidney disease grossly, it was all cysts, wasn't it? It was like a big sponge with a lot of big holes, maybe a centimeter or even more bigger. It wasn't the tiny little 1 millimeter cysts you get with like the sponge kidneys. And another thing that you should say to be intellectually honest is that if I said to you, is this adult polycystic kidney disease or the autosomal recessive variant, childhood polycystic disease, which has all the features of autosomal recessive in terms of appearing early, being uniform, you'd say, I don't know. And that is the correct answer, I don't know. And I mentioned this in one of my lectures, and somebody said, well, I thought maybe there's a way you could tell, and I thought one of our pathologists said that. And in all honesty, all you could see are cysts. And if you want to describe the cysts further, Honestly, if you want to say that, well, it looks like they're lined by cuboidal epithelium or nothing, uh, there is no right answer except what you honestly can describe. I don't think if there are some lining cells here, they look awfully flat to me. They don't look epithelial. They don't look like from a tube. They could be very, very flat, simple columnar epithelium. That would be my guess. And you say, well, what's the stuff between them? Could that be some maybe residual kidney parenchyma? Because some of those little things that look like they're epithelial lined maybe be residual small tubules. I would say, yeah, that's what they look like. Polycystic kidney disease. You don't need a microscope for that one, do you? So let's move on to the next one. And that will be K61. Which looks like it's right here. Oh, you're going to like this one because it's really a going to be a case where you recognize it as kidney and you remember the normal features of a kidney, and then you look hard. Sometimes you have to look, you know, very tediously at the whole thing and not jump to where you think your attention should go to. But at this point, I think nobody here would doubt that this is a kidney. You could see glomeruli. You could see a lot of tubules. I think in all honesty, you'd have to say that some of those tubules, you know, have some occasional inflammatory cells around them. Don't you agree? So I say, well, is this another pyelonephritis or interstitial nephritis? Well, from a descriptive point of view, maybe. But remember, we said the kidney has basically three components. It has glomeruli, it has tubules, collecting ducts of various types. It also has blood vessels. We've kind of been neglecting the blood vessels, haven't we? So, in all honesty, what would you say about that blood vessel there? Look at it. It only has a really tiny lumen. And it's not cut perfectly flat. It might be cut a little bit on edge, but you almost can't even see the lumen. It looks like the entire wall is thickened, and it looks like the entire wall is fibrotic. And if you didn't believe that was fibrous tissue and you did a trichrome scan, it was blue, then you would believe it was fibrotic. So we got a kidney here, and the glomeruli look okay, and the tubules generally look okay. There's some peppering of lymphocytes. And then we got blood vessels, which are pretty small. These are not major arteries. They could be arterioles or small arteries, which look like they're kind of sclerosed. But the pattern of damage or sclerosis to that artery does not look acute. It doesn't look like there's onion skinning. It doesn't look like there's granular fibrinoid necrosis. It looks like it's just sclerotic. Anybody want to venture a guess at this point? We talked about it under, like, I think the first topic, under vascular diseases of the kidney, because it probably is the single most common vascular disease of the kidney. This is benign nephrosclerosis. Okay, and we said, well, could those arteries be parts of atherosclerosis? So, you know, and that's something to think about. Generally, they could be, but remember, atherosclerosis is usually like larger arteries. Another thing is, you know, there's no calcium in there. There's no plaque, is there? And even though you might not know that because you haven't had the topic yet of vascular path, it's just a pretty sclerotic, very much narrowed blood vessel, benign nephrosclerosis. Simple question coming up now, just to see if you kind of remember from yesterday. What would your diagnosis be if those blood vessels were not just kind of quietly sclerotic? What if there was actively necrotic? What if there was layering or onion skinning of the wall and of the endothelium? What if they had fibrinoid necrosis? Would you call that benign Nephrosclerosis? Yeah, that's exactly what malignant hypertension. So I'm going to show you a picture, and we did it before, somewhere along the line today, where we see not just quiet sclerosis of the blood vessel, but onion skinning and all these things. That's malignant hypertension. And it makes a big difference because benign nephrosclerosis may not even result in much hypertension, but I think you know what the rule is with malignant or active destruction of the vessels. This is something that is very, very, very serious, has a high fatality rate. Okay, is there any more questions I want to ask you about this case to either think about or answer? Oh, yeah, here's a question. The glomeruli look pretty normal to you? Look pretty normal to me. Question number 2. If the end result of extremely narrowed small arterial vessels of the kidney persisted, what do you think that patient would have clinically? Hypertension, right? So most of the benign nephrosclerosis, most of them are any condition of the kidney, anatomic, physiologic, which results in reduced blood flow to that juxtaglomerular apparatus ultimately is very likely to have a patient that's hypertensive as well. Okay, how about the next case, SC64. And these are all things that we talked about and all things you could refer back to on the PowerPoints if you still have them there. And we're going to go to SC64. And it looks like that one's over here. Instantly recognize it as kidney. And even though the people online can't hear me, if you look at SC64 near the top of the list, you'll know exactly, you'll be seeing the exact same slide online that I'm seeing offline. Okay. Seems like we're seeing something funny here, doesn't it? Are we seeing really good glomeruli or not? Do we seem to be, oh, here's a glomerulus over here. Oh, maybe there's one over there. I don't know. Let's zoom in a little bit more. And this is going to be something that I hope I'll be able to explain to you. There's a normal glomerulus there, right? You might have to use a little bit of intuition on this case. That glomerulus looks pretty normal, doesn't it? What is that round thing and the other round thing next to it that kind of looks like a glomerulus, but you don't see any cellular detail? It's all pink. It's all hyalinized. It's all sclerotic. Would you say that many of the glomeruli in this field, because we've only found one really good one, and look at almost all the others are kind of like wiped out. There's one that's partially sclerotic. That one is fully sclerotic. That one is. And I'm not too sure whether these are tubules or what, but let's move around a little bit more. That glomerulus is almost completely sclerotic, right? You don't see those nice capillary loops and everything. There's one that's almost completely sclerotic. I'm having a hard time finding normal glomeruli. There's one that's sclerotic. There's one. There's a couple. This one maybe doesn't look so bad, but for the most part, most of those glomeruli are fibrotic. And if you thought maybe that was amyloid, rather than fibrin, you might do a Congo red stain. But let's say you did the easy stain first, a trichrome, and all those glomeruli were green. You know that that's fibrous tissue, right? You know that that's collagen. So we have a situation in the kidney. Looks like it's probably long-standing or a chronic condition in which the glomeruli now have mostly fibrous tissue. And we remember that the endpoint, sometimes long endpoint of chronic inflammation, is fibrous tissue. And I mentioned this, if somebody has the PowerPoints there, we could really make this very, very, very simple, because even though we remembered that there are various types of glomerulonephritis, acute. I said most of the chronic glomerulonephritis look very, very much the same, is that the inflammatory, the destructive process has been going on long enough, so most of those glomeruli are now just hyalized with fibrous tissue. So if you were to go to a rock lab, and maybe some of you are, and you did a right mouse click on some of those slides to see what their image number was, and you went to slide number SC64, which I also have here, the diagnosis is kidney chronic glomerulonephritis. I hope that's logical. It certainly is logical to me. I have another one here, but I forgot to put the number down, so I can't show it to you. So let's go to another case. And these are going to be all simple, common things that we've mentioned. And let's go to 4153. And I really do believe that you are having a good general feel for what a normal kidney looks like and the various ways kidneys can look abnormal, like abscesses or infiltrates of inflammatory cells or hyalinized glomeruli. Let's go to the next case, which is 4153. Which is going to be alphabetical before the 4153. You know, this is an awful lot better in the days where you had to yank out the microscope yourself and then answer a whole bunch of questions from a workbook and hope that somebody that was in your lab knew what he was looking at so they could help you. This is a hell of a lot better, and that's why I do it. Okay, 4153, here we go. We have a kidney. I think you can see a lot of little tubules. Whether you can recognize glomeruli clearly or not, I don't know, because I'm having a hard time seeing them, which is why I'm going to blow it up a little bit more. Can anybody here recognize really good glomeruli yet? I don't know. Good, well then let's blow it up. That's why we have a high power. Oh yeah, there's a bunch of them, right? Let's say I told you to count them. You'd say 1, 2, 3, oh, maybe 4 over there. I don't know, but there's another one here, 5. The glomeruli overall do not look too bad. And there's a glomerulus down there, and it doesn't look too bad. What's the thing here that comes to your attention? Is it in the glomeruli or is it in the tubules? It's in the tubules. Once again, there is stuff which looks like peppering or infiltrates of some kind of stuff, and it's, let's say, in or around the tubules. Now, let me ask you the next question, because I'm going to blow this up again even more. Can you recognize this thing here as being a tubule? Can you recognize maybe this thing as being a tubule? Can you recognize this maybe as being a part of a tubule? Here's the key question. Are most of those inflammatory cells, we could decide whether they're neutrophils or macrophages or lymphocytes later, are most of those inflammatory cells in or between the tubules? I'll be happy for the first honest person that takes a stab at it. In or between? Now see, if I had the online people here, I'd have probably 2 of them say in and 5 of them say between. This is primarily interstitium, isn't it? It's not really within the lumen. And you can look in more places, you know. It's not really within these lumen. There's a couple stuff, but most of these inflammatory cells are between the tubules. Remember, the interstitium of the kidney is just a theoretical space. So if you could see a lot of space between tubules, chances are there's something infiltrating there. How many people would like to just say, blank, stop, interstitial nephritis? I would, because that's what it is. That's the name of the case. So if you go down to that case in Rock Lab and do the right mouse click on the slide, you'll know that you're looking at something that's labeled kidney interstitial nephritis. And you'd run down again in your head and you say, well, isn't there a bunch of things that could cause that? Like, we know that infections, obviously, because pyelonephritis could have interstitial components. We know that certain toxins, heavy metals, maybe a lot of drugs. We know that chemo can cause it. We know radiation can cause it. We know that depositions of stuff inside those tubules can cause a reaction around it, like uric acid and calcium. And we also saw another case of interstitial nephritis that was primarily lymphocytic, which was called probably like acute and chronic transplant rejection. So that's a differential. Is it fair for you to know the differential of an interstitial nephritis? I don't know. It might be. They could very easily ask something like that. You should at least know the main top ones. And that's why we've mentioned this a couple times in lecture, and we've got another case on it in lab here as well. Okay, let's go to an easy case. And somebody actually asked me about this case before, and I told her it was coming up. And here it is. It's case number 694. Which looks like you got to be here somewhere. 694. Whoops. Did I miss it? Oh, it's not 694. Oh, I'm sorry, B94. Here it is. I know some of you may be a little bit hesitant to just, shout out what you think. I know there's always a great, great fear of being wrong, and I think the online people are more hesitant because they know that I don't know who they are, and they know I don't care if they're right or wrong. And nobody wants to, look like a wise ass. Or let's say that was a kidney. Let's say you don't even know it's a kidney yet, but let's say I told you that was a kidney. Your first question would be, well, why does it look like so cylindrical? As you know, most renal biopsies are done with a pretty good-sized needle. In fact, now they're almost all done by radiologists who are very good at ultrasound-directed biopsies of all kinds of internal organs. Wasn't that way 20 or 30 years ago. It might have been more done by either the nephrologist or sometimes even the internist did them. But we have a very, very precisely cylindrical piece of tissue, and that's because that was squirted out from the inside of a needle. In fact, if you measured that, you could probably tell what gauge the needle was. And the next question is, at this power, be very honest with yourself. Can you tell it's kidney? Yeah. No or yes? Yeah, you can kind of see glomeruli already, don't you? Okay, and you can see tubules. Good. Let's zoom in on it a little bit. Ah, sure enough, we got glomeruli, we got tubules. Oh, that's really, really nice. Okay. Now, the tubules don't look too bad. Is there one single glomerulus on there that looks normal? Does it look like something is really radically wrong with those glomeruli? You don't see capillary loops. They're funny colored. And furthermore, a lot of the glomeruli, and I'll try to find a classic one, but believe me, there's a lot of them. A lot of the glomeruli, let's take this one for example, look like that part of the glomerulus may be normal, sort of, but then there's kind of a denser area that's moon-shaped, that's at the periphery of the glomerulus. And if you think that another word for moon-shaped is crescent, You would say, well, you know, that looks like the croissant that I had this morning for breakfast. It's the same general shape. Very, very, very easy case. And whenever you see crescents in a glomerulus, like is demonstrated here beautifully, you think rapidly progressive glomerulonephritis, something that is also has a very, very high mortality. So these are patients that are rapidly going into perhaps irreversible renal failure. And those are crescents. And it doesn't really matter what they're made out of. I think the latest feeling, and you could do a bunch of studies to identify it, but a lot of those cells are macrophages, and they certainly don't look like neutrophils to me. Perhaps could there be some necrosis or stuff in them too? Perhaps. But look, there's a nice crescent, isn't it? I'll make it just a little bit smaller. And now that you know that that's a classical one, let's look at some more sort of classical ones. I'll go down another notch, and I'll zoom around. And I think this one you might start to see somewhat of a crescent. What is that? Is that a glomerulus with a hole in it, or is that just a thickened blood vessel? That's a blood vessel, isn't it? Here's some tubules. But the big news here are these crescents. This is crescentic or rapidly progressive. Now look at, see? Let's see if we could find a normal glomerulus. I doubt it. We have widespread involvement here, don't we? Oh, here's one. But once again, it seems to be a little bit denser towards the outside. Diagnosis from Rock Lab from the University of Iowa. Kidney, rapidly progressive glomerulonephritis. And I don't know if crescent was in the title or whether I put it in myself. Okay, we got a few more cases here. Let's go to SC69. Very good case. In all honesty, what do I see? I see pink, I see red, I see open areas. Well, let's go to this open area, and let's see if this is liver or pancreas or lung or, what the hell is it? Let's, whoops, wrong button. Now it's pretty instantly obvious what this organ, what this tissue is, right? Instantly, I think the glomeruli is the first thing that hits us. We can see tubules in between. And what else do we see? Well, we see an area that seems to not have glomeruli and tubules. And furthermore, it seems to have kind of a interface between the kidney that it's inside of versus the stuff on the inside of that circle. We can see that there's a lot of big blood vessels inside there. Look at how big they are and how numerous they are compared to the rest of the kidney. So if this patient had an angiogram of the kidney, you'd think the radiologist might have talked about a hypervascular pattern somewhere, maybe focally. We know this is a focal lesion because it's only involving part of the kidney. So the reason why we have a microscope is to zoom up on high power. There's a remnant of a normal glomerulus. There's what you might call either a capsule or pseudocapsule or compressed tissue to make as though it looks like it may be fairly localized. But what we also have then is a whole wide variety of things. And let's say that this was representative. We'll go to another area if you don't think this is representative. And what would you say about the cytoplasm in all these cells? Pretty clear, aren't they? And it appears to be hypervascular. Maybe if we looked around, we might even see areas that were necrotic. I think you all know what I'm trying to point you to at this point, don't you? Let's say that the reason why those cytoplasm around the nucleus is clear is the reason why any cytoplasm is clear. Like there was some fat or glycogen-like material in there that washed out during the process. This is probably the best example you'll ever see, the best slide of a renal cell carcinoma. And that's why, even though it has the name hypernephroma often, and that's why in the old days they might have called it an adenocarcinoma because it arises from tubular-like structures, and some of it may look a little glandular. It's basically a clear cell carcinoma. Now the thing I put out, and I think I put on the list here, is I'm going to make an assumption here, and I'm going to make the assumption that when you had your general pathology chapter on neoplasm, you got to feel that malignancies cells have big, dark, irregular nuclei. In other words, and highly stained. In other words, pleomorphic and hyperchromatic. But in all honesty, don't most of those cells inside of that cancer look relatively uniform, not terribly dark, not terribly big? Oh, look at this one might have a nice nucleolus over here, maybe. But the thing I want to point out with renal cell cancer, because now we're talking about renal, we're not talking about tumors from anywhere else. The one thing about the nuclei of renal cell cancers is that they're remarkably benign looking. And even though they have clear cells, if this thing was from the brain or from the lung as a metastasis, and you looked at it and had clear cells, most pathologists would say this is probably a renal cell cancer. Of course, you may know that. Maybe the patient already had a history of one. Or maybe he has one that's still there that's not detected, but it was early enough to metastasize to the brain. You should also know that renal cell cancer, like prostate, breast, and thyroid, for some reason, which we don't know, has a remarkable predilection for going to bone pretty early as well. And is there anything else I want to say about this? Oh yeah, I do want to say another thing. One more thing. If those tumor cells in the kidney metastasized, where would they go? They'd go into the renal vein, wouldn't they? There are no lymphatics in the kidney. You kind of remember that from histology? There are no lymph nodes that drain the kidney. So if it really goes into the vascular system first, that's one reason why, even though the cells look pretty uniform, that's one reason why it's not generally one of the better cancers, because the first place it goes to is not just a local lymph node. The first place it goes to is going to be the lung, isn't it? Anatomically speaking. Okay, let's do another case. As long as I can see you're having so much fun with this case, let's go to another one. Let's go to, oh, you're going to love this one. In fact, not only will you love it, but I think you're going to get it right away. It's K97. And this is something that Dr. Jalan says, I have to show you. And I agree with him. I have to show you this. K97. Well, in all honesty, can we say it's a kidney yet? Or you want me to go a little bit up so maybe you can see some glomeruli right away, and then you'll know it's kidney. Yeah, you can see glomeruli here, right? And remember, the glomeruli don't look too bad, do they? But what about all of these structures that are surrounding the glomeruli? Remember, the tubules are supposed to have sort of a columnar or cuboidal single epithelium. Those cells are supposed to have a nucleus. But what if the cell was necrotic? Do you remember the concept of karyolysis, karyorhexis? The nucleus dissolves. These are necrotic tubules, aren't they? And that's why they look redder than normal tubules, because there's no longer blue nucleus there. It's dissolved. So, and also, in all honesty, you could say from this slide that the glomeruli don't look too bad. So whatever this process is, it's relatively sparing the glomeruli, and it's causing the tubules to be necrotic. This is acute tubular necrosis. I think I might have taken this picture almost exactly and showed it to you as a still picture when we were giving the discussion on it. And do you kind of remember what causes acute tubular necrosis, the two general types of causes? Well, ischemia, you can think of those cells as being infarcted if they lose significant blood supply. And then a variety of drugs, most commonly of which are antibiotics. But we also mentioned contrast agents too, which don't cause it as much as they used to because they've made some little changes to their contrast agents, you know, to make them less toxic. But those are the classical causes for acute tubular necrosis: ischemia and drugs. Okay. Want to do another one? Let's do K270. And I hope you don't think I'm showing you exotic cases. I hope you think that everything I'm showing you is stuff that when I give you the name, it's logical. So here, let's go to 270, which got to be like around here. And, oh, I think you could probably tell it's a kidney already, right? You see, there's a glomerulus there and there and there. Are you with me? You think this, and probably this might be an area that is probably a medulla because it looks like it's mostly tubules. You don't see many glomeruli. But we know that this whole area out here has a bunch of glomeruli. Can you see them? Or should I assume just because I could see something that you can't? Can you see the glomeruli? Please, if you do, recognize them. I need to know this. Okay. So let's zoom it up a little bit. And yeah, there's a bunch of glomeruli there, all right. And there's a nice blood vessel, isn't there? And what else do we want to say about this, really? I'm prejudiced by this case because I know what the diagnosis is. So I'm finding an area that demonstrates it well. Glomeruli look relatively normal. I'm zooming in the middle part now. Okay. Take a look at the tubules. Most of the tubules are preserved. You can still see the nucleus, right? But do you think that some of them are gone? Like, look at it. It looks like a couple of these nuclei are just about gone. In this tubule here, I think they're mostly gone. In this tubule here, it looks like there's not only damage to the tubule, but some kind of thing which we don't see filling up the tubule. Remember, one of the things we said that causes acute tubular necrosis, besides ischemia, is a variety of drugs, and antibiotics, contrast agents. But that's not really the whole list, is it? You could probably find a list of 30 or 40 things. I just mentioned the top 3. This is ethylene glycol toxicity. This is antifreeze. Okay, so you know when you see a person that has acute tubular necrosis because that stuff inside the tubules is antifreeze, you probably know what was going on. It's probably a suicide, right? So this is acute tubular necrosis secondary to ethylene glycol. Not quite as severe as what we saw. It's not like all the tubules were wiped out, just parts of the tubules here. But in addition, there's some substance inside there as well. Okay. And I'm not saying that's pure antifreeze. I mean, it's something that has been filtered or tried to be filtered and is causing a lot of damage in the tubules. Oh, here's an easy one, and it's a nice one. And I know you're not going to get the diagnosis, but I know you're going to probably zero in close to it. It's going to be number 4050. And that's before the alphabet, isn't it? 4050. And we got to be near it. 40. Whoops, here we are. Question. What is the time? 5 what? Now, this normally should go to about quarter after. Is that correct? So we'll call this the last case. And then we'll decide tomorrow whether we want to put on a few more last cases or when we want to start in on CNS. Let's call this the last case. I'm not tired, but I don't think it's fair if you're working hard, and I could tell you are. If you're working hard, it's not fair to reward you by making you work longer than you have to. And that's exactly how I feel. And it's not fair to me either, because I'm working pretty hard. 4050, kidney case. Here it is. I think it's instantly recognizable as a kidney. I think the first thing that instantly comes to your mind, of course, because you're pretty good at this, right? There's some kind of cystic lesion. And remember I told you that cysts are infinitely common in all types of kidneys. Now, if this is an incidental cyst filled with fluid, it's probably not what killed them, and it may not be the primary thing that you're looking for. And, you know, for some people, they would say, renal cyst, next case, please. And that's the problem, because when you see something that comes to your attention, and this is true not just in pathology, it's true with your patients. When you see your abnormality, you go, boom, that's it. And then you fail to look at the other little things around it. So yeah, that's some kind of cyst. And what else? Well, we could see a lot of tubules here. It looks like this is part of a medulla. It looks like on the right side it's cortex. So let's look at the glomeruli too. Well, I don't really see any good glomeruli here, so let's move around. I looked at all these cases beforehand. Oh, look, there's part of a glomerulus there. Oh, look, there's a glomerulus there, too. And, oh, there's a glomerulus there. And there's part of a glomerulus there, a couple even, and there's one there. But let's remember about this glomerulus here and this glomerulus here. There's something wrong with them. Maybe it doesn't stick out right away on all of them, but let's zoom down to this one. In all honesty, how would you describe that glomerulus? Would you say, well, it has normal capillary loops, it has the normal mixture of 3 types of cells? Or would you say, you know, it looks like a large portion of that thing is hyalinized. Hyalinized means it's pink, acellular, sometimes granular, or glassy, if you will. And could that mean fibrin? Could that mean fibrous tissue? What are the other things that you've learned about, especially in general path, that could be hyalinized on microscopy? Amyloid is one of them, isn't it? So let's say that your friend says to you, well, that's just, you know, some fibrosis due to some crazy thing, forget it. But then somebody says, well, you know, it looks a little bit more glassy than your average fibrous tissue. You have a fight, and you're going to make a bet now, and somebody says, well, I bet you if you do a trichrome on it, it's going to be green. So you do a trichrome on it, it's not green. So what are the other causes of hyalinization? Well, fibrin. Let's say you do a fibrin stain. Fibrin stain's negative. Well, let's do a Congo red stain. And bingo, you do the Congo red stain, and you put it under your regular old microscope, and it's red. So, hey, wait a minute. Let's also polarize it now that it stains red with Congo red, and bingo, it's green. It's apple green. It shows granny apple green birefringence. You got your diagnosis. This is a case, kidney, if you go to Rock Lab and you look at case number, oh, which one are we on? 4050 happens to be amyloidosis. Okay, so this was a lab. You know, we're going to have more labs. Generally speaking, historically, I do about a 2-to-1 ratio overall, which is not always consistent. Like if this was the chapter on neoplasm, I would probably spend just as much time in neoplasm lab or more. I did like 2 full days, 5 hours on neoplasms and then 5 hours in lab. And I don't know if you enjoy this. I don't know if any of you enjoy medical school at all. I didn't enjoy medical school. But in my opinion, because that's what I'm getting paid for, an opinion, this is good for you. This gives you a feel for the disease. We can talk about diseases, we can show statistics and epidemiology, but the best way to really understand disease is to remember, doesn't that say 1,000,000 times more than if I write out the word amyloidosis of the glomeruli? You're actually seeing it there. So we'll call it a day. And I don't know if there's any online people here because I betrayed them, but I'll switch back to the computer and play a going away song. And if you want to come up before or during or after with questions, feel free to do so. And I hope you enjoyed the first lab, because unless somebody puts a gun to my head, we're going to have more of them. And in this case, we took almost all of the kidney cases. In some things, some other labs, we may just do like half of them or a third of them. But I really feel it's much more important to actually give you the slide with people's tissue on it than to just Google a picture from, Robin's textbook or something like that. Thanks for coming by today. I appreciate it. How did we get that thing on there? I'll be right with you.
Okay.
Oh, is that for me? Thank you, thank you, thank you. Thank you for the lights.
That's correct. I didn't sign in.
Goodbye, everybody.